Corn's late.
Guys, it's about 4:30. I will hang tight for another minute or two. Let's see if we can get a few more people in, and then we'll get started. All right, we'll go ahead and get started. I hope everyone's doing well. Again, this is going to be recorded, so keep that in mind, please. I'll ask if everyone who could turn on their cameras goes ahead and turns on their cameras, just so it makes it a little more interactive, and it makes me feel like I'm not just talking to myself, so I appreciate that. We are going to cover adult deformity today. And this is a bit of a follow-up to Dr. Koski's talk from a couple of weeks ago, when we talked about sort of thoracolumbar deformity. So now we're going to talk a little bit about cervical deformity and how we approach it. thinking about sort of key concepts, thinking about some decision-making algorithms, and then talking a bit about some of the surgical techniques and procedures we can do to help folks with these conditions. Just from a standpoint of parameters, any questions, there's a small enough group of us, just interrupt, go off mute, ask the question. I'm happy to be, to stop the conversation and focus in on whatever questions you guys have at any point. Similarly, at the end, we'll circle back and make sure we get a chance to ask any questions. So feel free. With that, let's get started. So these are my disclosures. There's nothing directly related to this field, this topic. There are some implants that you'll see along the way. If I have any relationship with them, I'll try to point them out. But in general, the talk is relatively agnostic to any one implant manufacturer or any one product of any type. So again, I like to have three goals from any conversation we have. So these are my 3 goals for today. I first want to identify what the impact and the different causes of cervical deformity are. 2 is I like to leave with everyone being able to at least define what the strategy for evaluation of a deformity is. And then 3, I want you guys to recall or think about what are the key considerations in surgical decision making. So, we'll start with a patient of mine. I think stories are always really powerful. So, this is one of my patients from a while back. He's a 54-year-old gentleman. He's a laborer. He's actually the husband of another patient of mine. And I met him at her pre-op visit. So we got to talk very quickly about his deformity at that point. But, he's had this progressive change in his alignment. He gets to the point now where he can't drive anymore because he can't see and look around. He has a difficult time swallowing. So he's actually lost weight because of his difficult time eating and drinking. And then if you ask deeper, he's unable to really socialize, or he has a challenge working as well. And so if we look at what's going on with him, there's a number of things that come into play with regards to his deformity. He certainly has a kyphotic deformity, and he certainly also has a translational deformity where his head is literally shifted anterior to his thoracic spine. And so if we think about chin on chest deformity, it's this combination of kyphosis and translation, and that becomes really important when we get to talk about correction. Okay, but let's not get there quite yet. Let's first spend a little time understanding what normal anatomy looks like. We use this number a lot of normal lordosis being somewhere between 20 to 30 degrees. But again, we need to remember that lordosis will vary in the cervical spine. It'll vary by age. As we get older, there's less lordosis through the subaxial spine and maybe more of the lordosis through, occiput C1, C2. So keep in mind that normal numbers will vary based on age. And then it's a balancing act. And we oftentimes have used this old analogy of the cervical spine balancing the skull, kind of like balancing a bowling ball on a bowling pin. And what that means is to think about the idea that the balance can be precarious, right? When it's just right, it works really well, but small deviations from normal can be quite catastrophic. So if we think about normal biomechanics, if we look at the normal structure of the spine, right, there's going to be this load distribution that goes on between the anterior elements, the disc and the end plates and the vertebral bodies, and then the posterior elements or the facet joints. And that breakdown is generally in about thirds. So about a third of the weight goes through the middle of the body, 2/3 to the posterior aspects. And that creates in a lordotic spine, a weight-bearing axis that's a little bit posterior to the vertebral bodies, right, in a lordotic spine. And so we have to keep in mind that idea of weight-bearing axis and how that comes into play with regards to deformity or kyphotic deformities in particular. And as we go towards kyphosis, there's a bit of this cycle, right? There's a bit of a vicious cycle that goes on. That weight-bearing axis gets transferred anteriorly, which then puts the posterior structures, the paraspinal muscles in particular, short external rotators as well as the splenius muscles, it puts them at a mechanical disadvantage, right? They're really working against their normal length, their sort of length force relationship that they were designed to work under, which leads to pain, but then also may lead to weakness of that muscle or ineffectiveness of that muscle, and then a progression of the deformity, which then further shifts the axis anteriorly. And so as we move ahead, we want to have a little perspective on what are these varying degrees of kyphosis that runs a spectrum, right? Not one deformity is going to match the other. And a lot of the times as we think about identifying different parameters of these deformities, it comes back down to classifying them, and specifically then trying to classify around ideas around severity and classifying around ideas of impact. So we're going to spend a lot of time talking a little bit later on about severity when it comes to some of the angular measures. But I want to start off talking about impact, and that'll be the next couple of slides. It's just talking about what does impact look like. So one impact could be neurological involvement. We know some individuals with deformity will present with myelopathy, right? And myelopathy may come across or may come about because of tension and elongation on the cord. We know there's also the potential for some front to back or A to P compression on the cord. And then also this thought of ischemia, right? These folks add a little bit of a tenuous blood supply to their cord, and might kyphosis make that worse. So there's the neurological presentation. And what do we know about neurology and deformity? Well, surprisingly little. There's been a couple of studies. This is one that we put out quite a long time ago now, where we looked at individuals with cervical degenerative myelopathy or cervical spondylotic myelopathy. And what we generally found was a trend towards worse myelopathy scores, MJOA, and also worse neck pain scores as patients shifted out of cervical balance. This is one of the first studies where we did a radiographic analysis to correlate with myelopathic symptoms. What else do we know about impact? We know that, as I mentioned with that story I told you about our patient Russell, that as you go into kyphosis, as you go into a forward position, you can develop dysphagia problems. You can develop even airway restrictions. And we have to remember that these elements of swallowing and airway function can be positional. So that's important as we consider the impact of the deformity, but it also comes into play as we consider, how we want to correct them and what position might we leave them in and how that might impact their ability to eat, drink, and function. And what we generally found in this study, which is a really good one, just looking at oral pharyngeal space on radiographs, is that not surprisingly, as you go into flexion, that space diminishes. And then really importantly, in the far right, in the picture that's labeled E and the X-ray that's labeled J, we see that as the neck is placed into retraction, the airway collapses down quite a bit and swallowing becomes very problematic. So you want to be sure that we're not locking in or fixing people into those positions on the right. If anything, we're trying to aim, hopefully, for a position like A or F in the non or in the shaded out sections here. And then quality of life is the other impact. So we measure these somewhat by NDI and by VAS neck pain, but there's probably a lot of unmeasured components of this. And this is a challenge to really get good arms around physical function, social interactions, mental health, because the number of patients presenting to any one practice is relatively small. And so it's going to really take, I think, a really large concerted effort to really define what patient-reported outcome impacts we have in this population, and that's sort of ongoing. So that's the impact. Now we'll talk a little bit about etiology and what the causes are. The causes run the spectrum, right? Like this list here: degenerative trauma, iatrogenic, congenital tumor, infection. You can pretty much use that as an etiologic checklist for almost any condition you ever run across as an orthopedic resident or a neurosurgery resident, right? Everything happens because of one of these problems, right? One of these underlying causative factors. So let's dig in a little deeper. Probably the most common reason we get kyphotic deformities in the cervical spine is because of degenerative changes, right? A loss of normal disc height, disc architecture, bad facet arthropathy with secondary instability. And maybe you'll ultimately get a fixed kyphosis because the osteophytes will bridge and prevent further collapse. So generally these patients with degenerative kyphosis are not going to come in with, the really dramatic chin on chest type deformities. They may come in with sort of swan neck type deformities where they're kyphotic through the subaxial spine like this patient, and then they get hyperlordotic in the upper cervical spine to try to crane their neck up and keep them forward. Oftentimes these patients present with quite a bit of axial neck pain as well as probably secondarily occipital cervical pain. Another one is the iatrogenic kyphotic deformity, and this one, the most common one that we think about is post-Lamy kyphosis. The exact incidence, I'll be honest with you, in adults is a bit of a question mark. The reported literature, which is mostly case series, We'll run the gamut, anywhere up to half of patients who have laminectomies developing kyphotic deformity. I'm not sure if that holds true or not, and a lot of it depends, right? If you have a patient with a really stiff neck, where you've got osteophytes that really don't allow for much motion, or you've got discs that are collapsed down and near ankylosed, that person's probably not going to fall into kyphus. But if you take the flip side, which is the pediatric world, right? If you take pediatric patients who are having cervical laminectomies done, which is most often for tumors, those individuals, those kids have a really high propensity for post laminectomy deformity, and it can be quite dramatic. And so that's something in that population when you're working over at Lurie's, you're working on pediatric patients in the future, to keep in mind that that a laminectomy in those kids, can be done, but it just really needs to be done with a lot of caution, and a close eye on the idea that deformity may develop later. The second most common reason that we see people with deformities, probably second most common, would be some type of an underlying neuromuscular condition. And oftentimes these patients don't have a firm diagnosis when they see you, right? In the neurology literature, this is called dropped head syndrome, which I thought is very, it's very apropos. It's pretty easy to describe, and it's kind of what's happening. I'm surprised it didn't come out of our literature, but it's the neurology literature that talks about dropped head syndrome. And this ends up being a problem with either the muscle itself, so primary myopathy, or most commonly a neuromuscular junctional disease like myasthenia. And these individuals may start off with relatively normal alignment, but as the day goes along, or as they're asked to maintain their head alignment, they gradually drop their head, progressively forward. And so the reason this is so important, as you can imagine, is if we don't identify the underlying cause of a substantial deformity like this, if we don't get to the root cause and treat it, we may fix one problem only to be faced with an even bigger problem later on, right? Because of the underlying neuromuscular disease or primary myopathy. So keep that in mind as we see these patients, and really ask those hard questions. And oftentimes it's a pretty extensive workup before we get to the answer, but it's worth pursuing. The most common reason that we do surgery for cervical deformity stems from ankylosing spondylitis, right? And so you'll see, we'll go over some cases here shortly, where we see this as being a really common cause of deformity, but also then the most common reason we surgically correct them. And many of our surgical techniques are really based on the experience with ankylosing spondylitis patients, and geared at correcting their deformity. And we need to understand that that might work well for them. It may or may not work as well for other causes of cervical deformity. If we look at the literature on ankylosing spondylitis, it's actually so common that even the American College of Rheumatology has come out with treatment guidelines. This was an update, I think, from 2015 from them, and they basically talk about recommending, this was pretty strong language actually at the time, conditionally recommending against elective spinal osteotomy. So I'm going to take a quick side note on this one, so we dig into it a little bit. And they appropriately identified some really key problems, right? They said there's a lack of high quality evidence, certainly ones with relevant outcome measures to support surgery. There's plenty of reported complications in the surgical management of these patients. And so that was sort of what drove their decision. But they also put a disclaimer that, severe kyphosis with a loss of gaze could be considered for an osteotomy at specialized centers and with surgeons with a lot of experience. So they put some caveats in there to sort of hammer home the idea that these are not cases that should be taken on lightly, but also to challenge, I think, us as surgeons that we need some better evidence, right? We need better evidence to support the work that we're doing. And so as far as AS goes in the spine surgery world, I think we've got some great unanswered questions. In terms of on the one hand, the development and progression of disease, we don't really understand which AS patients will develop it, which ones won't. So what are the risk factors? Are the quote unquote new biologic therapeutics going to help, or do they not help? Right. So what's the impact in AS, which we don't know as much as we do know in the rheumatology, in the RA world. And then on the other side is this idea and this need for prospective validated outcome studies. And to their credit, there's been a couple of deformity study groups that have tried to collect and capture patients into a single database. And I think we'll look at some of their studies as we move ahead. And that's great. And it's really good that they're prospectively capturing this data. But even the largest clinical studies right now generally are about 100 patients or less. So just to give you some perspective on things, it's still a really small cohort of patients. And so there's a lot of heterogeneity to it. When we examine these patients, we want to think about, again, what's their neurological assessment, myelopathy, radiculopathy, myeloradiculopathy. Radiographically, and we'll get to some more pictures in a minute here, but we obviously are going to start with plain radiographs. This is a situation where FlexX films sometimes are helpful, but dynamic films, rather bolstered films, so having them lay down, extending back and seeing what gravity does when gravity is neutralized. Traction films can sometimes be helpful, especially in degenerative kyphotic patients. And then we've got our advanced imaging like MR and CT myelography. And we talked a little bit about this with Dr. Koski's talk in how we use radiographs to assess flexibility of curves. And we're going to get to that in just a minute. There's a number of measures we can look at in terms of measuring kyphosis in the cervical spine or measuring deformity. I like to break them down because there's so many of them between upper cervical and sort of and then subaxial to global measurements, right? So upper cervical is really locked in between O and C2. So you look at the angle between the occiput and C2. You can do the C1, C2 angle. Those are relatively well-defined angles. And they often, again, times come into play as we consider occipital cervical reconstructions. But if we hone in on most of deformity that we're going to treat, it's in the subaxial spine or maybe even in the thoracic spine. So then we start thinking about Cobb angles. And we went over, I thought Dr. Koski did a great job describing how we measure Cobb angles last time around, but it's the same concept here. You take the bottom of the C2 end plate, the bottom of the C7 end plate, and you measure the angle that's subtended between them as your C2 to C7 Cobb angle. We then look at the C2 SVA. So if you drop a plumb line from the middle of C2, you measure that distance to the back of the C7 disc space, then that'll give you your idea of your C2 SVA. And then the last one is this idea of T1 slope or tilt. And I think that's a really important one, kind of here in this bottom in purple and blue. And that is sort of the equivalent of many of the things that we talked about with regards to pelvic incidence and pelvic tilt. Sort of the floor, if you will, of the cervical spine is the slope of T1. So you can imagine in somebody with a really high thoracic kyphosis, T1 is going to be sloped really high, right? That individual is going to have a very different appearance and a very different deformity issue than somebody with a relatively well-preserved or lower T1 slope. So T1 slope is a really pretty, it's a pretty critical determination here. And what we're really looking for is that balance probably between C2 to C7 Cobb angle and T1 slope. Just like in the lumbar spine, we think about lumbar lordosis and pelvic incidence, trying to balance the two out. So really hone in on those two dimensions. So again, what do we know about from the literature? Well, again, not a whole lot, unfortunately. There's been one study that was a retrospective study where they looked at individuals who had surgery for cervical myelopathy. And they basically said that outcomes, NDI, SF36, PCS outcomes were worse in patients who after surgery had a positive SVA. So C2 is shifted well over C7 of more than 40 millimeters or 4 centimeters. So I think you have to take that with a grain of salt. It's not very granular, but it certainly does at least suggest that SVA and cervical alignment has an impact on functional outcomes, at least after surgery. We talked about T1, again, just to reiterate here, I forgot I had the slide in here, sorry about that. And again, think of it like the foundation for the spine, right? And a level foundation completely changes the architecture of what comes above it. So those are the radiographic measures. The last things to talk about are probably some of the clinical measures of deformity. Again, these are as objective as possible. We look for things like angular motion. You can look at the distance from the chin to the chest, 1, 2, 3 finger breaths. I'm not sure how objective that is. Everyone's fingers are a little bit different sized, right? But the one that we probably lean on the most is this concept of a chin-brow angle, which is shown in the picture on the left here. And really what that is meant to do is it's meant to measure horizontal gaze. So if you can imagine that chin-brow angle, which is a tangent from the face to the vertical to the floor, is meant to be a measure of gaze. So a really high chin-brow angle, usually of negative 20, 25 degrees or more. Folks are stuck down, they're looking down, they can't quite look up. So they lose the ability to socialize, they lose the ability to interact, they lose the ability to see the horizon, to drive. And if it really gets bad, they'll lose the ability to drink or swallow. And I think in the past, I've told you guys, go ahead and, try to take a drink of coffee or a drink of soda or water with your neck extended, and then try to do it again with your neck flexed and retracted. And it's really hard to swallow in that position. So chin-brow angle actually ends up being one of the major determinants that we use in the clinical assessment of patients with cervical deformity. And it's certainly one of our primary targets for correction. And I'm going to talk a bit about how we measure correction in a few slides. So a lot of that's going to come back down to these ideas around chin-brow angle and trying to maintain a relatively horizontal gaze, which means a relatively perpendicular facial orientation. I put this on here so you guys can have it for future reference. This is one of those groups that I'd mentioned, the ISSG, that looked at and suggested a cervical deformity classification system. This is very similar, and it looks probably similar to the Schwab classification that Dr. Koski had mentioned previously. And it's a way to quantify or classify folks with cervical deformities in terms of the location of deformity and the severity. And I'll hone in on a couple of things here. One is the horizontal gaze measure, chin-brow angles on there. And then this concept of cervical lordosis minus T1 slope, meaning what's that mismatch between the two of being pretty critical determinants. I'm not sure many of us utilize this on a day-to-day basis because it is pretty complicated, and intra-rater reliability is fairly limited, but it does give you some of the concepts, and it's nice to go back and think about all of these factors as you're considering surgical correction, certainly for folks with deformity. All right, let me take a quick pause because we're going to go into talking about the actual correction and management. Maybe I'll take a quick pause and just see if there's any questions from you guys. Feel free to unmute and ask away. I'll wait a few seconds, otherwise we'll keep moving.
Hey, Al, how do you evaluate somebody who you think has a flexible deformity? And how would you classify that? And what kind of imaging would you take before you go and offer them a osteotomy?
Yeah, I'm about 4 slides away from talking about how we assess flexibility, because it's absolutely critical. And to Dr. Sue's point, that should be the first question you ask when you're starting to then, as you go from the causes of deformity and the severity of deformity, the next thing you're going to ask is how flexible is this? So I'm going to get to that in just a second. All right, I'll keep moving, but anybody feel free to step up. So if we think about the goals of management, how do we want to manage these patients? Obviously, we want to think about prevention, right? So as we think about some of our primary procedures, we want to keep in mind a notion of how are we going to optimize their alignment? How are we going to keep them in a good position so that we're not creating deformity? And I think that's a conversation we have in the lumbar spine a lot. We probably should have it more in the cervical spine. We obviously want to decompress neurologically anything that we think is symptomatic, whether that be cord or root level compression. And then again, if we're going to talk about managing the deformity itself, we want to restore both local and global alignment to a reasonable degree. And then we want to think about long-term stabilization. So those are the big picture goals in management of these patients. So to Dr. Sue's point, I think, again, I like to simplify things down to 3 things. I think if we can think of things in 3s, it's easier to remember. So there's probably 3 key steps in decision-making, for me at least, when I'm looking at these patients. Step 1 is to determine the flexibility, right? Is this a flexible or a fixed deformity? Because it changes the conversation entirely. So flexibility is really critical, and that should echo what we talked about last time around in adult deformity, right? A flexible curve versus a stiff curve, very, very different options. The second thing that we think about is to determine the location of the deformity. Are we talking about a high cervical, mid-cervical, cervical thoracic deformity? Is this really a thoracic deformity that's creating secondarily a cervical deformity? And then obviously what's the neurological impact of those deformities? So location and neurology are the next, I think, key step. And then the third one is really then based on step 1 and step 2, figuring out what is the best surgical approach, whether that's anterior or posterior, whether that's a specific osteotomy technique, whether that's the type and levels of fixation, so that we can optimize our goals that we mentioned earlier around deformity correction, stabilization, and neurological decompression. Let me start with flexibility, because that's really that's probably, gosh, I'm going to guess half the battle, right? Is flexibility. So ways to assess them, like Dr. Stewart asked. Obviously, you'll see them in the office. You'll see maybe static X-rays like this. I really like a supine examination. You know, sometimes while the patient's just sitting there, you can manually bring their chin up. You can kind of put a counter force along their upper thoracic spine, bring their head up and see how flexible they are, right? Just by doing it manually, that's one way. I also like the idea of laying them flat, giving them a little bolster behind their shoulders, whether that be you know, a couple rolled up towels or a pillow, and let their head hang free. And if you need to, put them in that position, go on and see your next patient, come back 5 to 10 minutes later, or however long, and see if with time, how much have they stretched out. So a supine examination is really helpful for me. It's a little more time consuming, but I think it gives you a lot of information. In the hospital setting, you can do traction. You can put some folks into traction and see how much they straighten out. I sort of mentioned manipulation earlier, like the idea of manual correction externally. Then you can look at CTs as well to look for areas of ankylosis, right? And in a setting of somebody who's flexible, right, they don't have ankylosis. Let's say this person lays down and they flatten out mostly, then correction may just be a matter of creating segmental lordosis at each of these locations, right? And that you can do through a multi-level ACDF, and then locking that in position, right? So a flexible curve may be able to be treated with relatively standard techniques of interbody decompression, interbody grafting, anterior and posterior instrumentation, and still get a very, very good correction. So flexibility is super critical. And I think most of the flexible curves that I've seen over time tend to be either the iatrogenic deformity, so folks who've had a laminectomy or a failed laminoplasty, or it's going to be folks who have really bad either degenerative kyphosis or, you know, rheumatoid involvement in the cervical spines. Those are the folks who are pretty flexible. The next thing to discuss is sort of where to make the correction. So if they're more of a fixed deformity, right? Is this a fixed deformity in the substance of the cervical spine? Where's the apex of the deformity, like you see on the left? Or is this more of a cervical thoracic deformity, or a more global deformity, if you will, of the cervical spine? Because arguably the corrective maneuvers for the one on the left and the one on the right are very, very different depending upon patient symptoms. So let's focus in on the CT, on the cervical thoracic correction, because I think that's what we generally see more of. And it's certainly where a lot more of our thoughts are heading right now. There's osteotomies for correction. Some of these are basically analogs of the thoracolumbar osteotomies that have been performed. Smith-Peterson or Ponti type osteotomies. In the cervical spine, those were called Simmons osteotomies, named after Professor Simmons from Buffalo. There's also now increasingly more pedicle subtraction osteotomies being utilized in the upper thoracic spine, and so we'll talk about pros and cons there in a minute. But before we go, you know, you again need to look at global alignment in these patients, because if there's a substantial thoracolumbar deformity, you probably should be addressing that first in most patients before you take on a cervical deformity. And I've got a great case at the end to show you guys what that looks like. So, you know, and what does that mean, assessment of their global balance? Well, for us, at least, it means generally getting full-length Scoli films or EOS films. Nowadays, we probably even go past the hips and start to look at the knees and the feet, right, to think about what lower extremity balance might look like. So thinking globally about the patient means looking at their cervical alignment, then their thoracolumbar alignment. Are they balanced or not in each of those segmentally? What's their spinal pelvic alignment look like? Do they look like they have a corrected pelvis or an uncorrected pelvis? Do they have hip or knee contractures that might be contributing to things? And in general, we like to work from the bottom up as opposed to from the top down, because you have more control over the overall, the end alignment, if you will, of all of these components. But I do want to stop, because I think usually at around this time in a deformity conversation, we start to dig into a lot of the radiographic numbers, right? We dig into SVAs and angles, and you take one measure and you subtract the other, and you have this targeted goal, like we heard last time about getting people back to some normal number. But I have to really stress that we're not treating an X-ray. I also put this out there that we're not solving equations. A lot of the deformity literature in the last 5 to 6 years has become really dominated by, logistic regression equations. And we have to understand the limitations of those equations, certainly both mathematically, but then also on the applicability of those equations to the individual patient. So I want to challenge all of you guys, when you look in the literature around deformity, read those things with interest, but don't be constrained by the math or by the equations you may see reported. And then I think we actually do want to be really human-centered in this discussion. It's easy to lose that footing when we start to talk about these really complex problems and really technically demanding, but also very fun and challenging cases. It's easy to lose track of the individual patient. And so what does that mean for me? It means we also want to think about some of the other considerations that's going to go into managing and taking care of these patients. Airway management can be a real challenge. Intubating these individuals with severe fixed deformities in particular can be a real challenge. I haven't had to do it, but I know other surgeons have talked about having to, do a tracheostomy as the index means of accessing the airway, right? If they're really kyphotic. So don't forget the airway management concerns that come into play, and include anesthesia or ENT in the conversation as need to. And then think broader about these patients. And I think we do a really good job at Northwestern of talking about this. And I think increasingly more and more centers are doing this, but really dig into their bone quality. Make sure you understand how osteoporotic are they, how osteopenic are they. We've evolved from DEXAs to looking more at CTs and Hounsfield's units, but there's probably even better and better ways to manage and measure bone quality. Think about posterior soft tissue coverage. These are a couple of examples of folks who came with deformities, and some can turn out okay with regards to wound coverage, and others can create real big problems. So it's not uncommon that we include plastic surgery at the index level procedure to help with closure, right? Typically that's muscle advancements that are done to help with closure. Make sure you've got good neuromonitoring capabilities to do these cases. That time around deformity correction is pretty high stakes. A lot of bad things can happen. And if you don't have reliable neuromonitoring, capabilities where you're working, these probably aren't good cases to take on. And really make sure you understand and know your neuromonitoring well. Again, think about their medical comorbidities and how that might affect the results of surgery and their recovery patterns. And then really think about what the goals of these patients are and what their expectations are. I think you'll be surprised sometimes what patients want out of these procedures may be very different than what the x-rays, would suggest, or maybe the equations might suggest. So we're going to wrap up talking with some of the corrective osteotomies that we consider amongst these patients. And this is where it gets fun for us. And it gets to be a lot more opinion now. The last part of this talk is a lot more opinion motivated than it is evidence motivated, but I think it's definitely the best part to talk about here for me. So I start with the simplest of the osteotomies, if you will, the oldest one that's been described, which increasingly is more and more of what I do in this case. I've kind of gone full circle. This is the idea of a cervical thoracic osteotomy or a Ponte osteotomy. What the image on the left is showing you is like a dorsal view of the spine. There's been a pretty wide laminectomy of C6, C7, and T1. And then you've basically knocked off the entire facets of C7 and T1 so that you've got this wedge shape there. And that Ponte or Simmons resection then allows for corrective manipulation and closure of that posterior-based osteotomy. Again, primarily for ankylosing spondylitis patients. And what does that look like? Well, back in the day, these are pictures from my fellowship time. We used to have these folks in a halo, and we'd have them, seated in the OR. We'd get them all situated in that position. We actually did this under awake anesthesia, so the patients would be intubated with a bunch of local anesthetic, but they'd be awake and being able to give us the thumbs up, like this guy is showing in the bottom right. We would drape them in an upright position, right, with a hip drape, and expose them in an upright manner as well, in a seated position. And there's some upsides to this approach. There's some surgeons who still really love this approach because it lets you look straight ahead as a surgeon. All the bleeding tends to go to the bottom of your field as opposed to pulling up in the middle of your field. And then you can see here what the instrumentation's in place, and a really wide laminectomy and a wide facet resection, probably a little wider than what I would do now. But the idea is to show width on the decompression around the cord. Another example, sort of again showing the left side. This is another operative case where you've got the kyphosis exposed, instruments and implants in position, and then really the image on the right is the one showing the osteotomy, right, where you now have the central lamina decompressed and the facets knocked off. And the idea from a visual standpoint or a diagrammatic standpoint is that you've created this wedge. This is showing a wedge through from C5 to C7, but bear with me, it's a similar concept. And you're then basically closing that wedge down, right? By both retracting and extending the cervical spine through that closure. But if you remember about ankylosing spondylitis, that's a really rigid anterior column, right? These aren't flexible anterior columns. So if you've got this closing wedge in the back, sort of something has to give in the front, right? And that anterior give, or that anterior osteoclasis, is the corrective maneuver that you run into or that you see in these cases. All right, so let's see if this works. This is an old video. Some of you may recognize the voices in the video, but what I really want you to hear is if you can hear that anterior osteoclasis, if you can hear that bone giving in the front. It's subtle, but it's there. You may have to turn your speakers up as loud as they can go. They can go up to 11, go for it. But go ahead and turn them up, and let's see if this video works here.
You're ready. Let me know when you're ready. Ready? Okay, go. Nice and slowly.
It was that little crack noise. Now, in the OR, it's substantially louder, at least, or it sounds a lot louder. And certainly it's the point where you're, as a surgeon, your anxiety levels are the highest sometimes. So it's really loud. But it's pretty dramatic correction that you can get. And I'll show you the CT images here in a second. Again, on the left is where we started with this patient. And on the right is where we ended up with the same patient. So you can get that chin brow correction, quite nicely with a pretty large anterior gap now and anterior correction. So really big angular corrections in these ankylosing spondylitis patients, and generally good results with this technique. This is a patient of mine that we started with, right? If you remember him, these are his Flex X films. He did have ankylosing spondylitis. We diagnosed him with that, had to get him evaluated for that first, but ultimately demonstrated a pretty fixed, rigid kyphosis, right? You can see bridging across the cervical spine on those images on the left-hand side. This is a standing clinical view of where he is. And if I look at his SVA, if I look at his chin-brow angle, it measured about 25 degrees, negative 25 degrees. And that's honestly, that picture there is with him looking up a little bit. He's kind of looking into extension. If we looked at him at rest, it's probably even lower. If I assess this individual, remember the 3 steps we talked about, fixed or flexible. So he's a fixed deformity. He has no global deformity. I think his TL spine, if you look at it individually, is actually pretty well balanced. We may be wondering a little bit about what's going on with his pelvis, but let's say that his TL spine is pretty well balanced. So he had a deformity that was limited to his cervical spine, and he showed, no neurological involvement. So with that in mind, I didn't think there was a global deformity. I thought we could focus on the cervical spine. I thought his problem was it was global, not in the middle of the cervical spine. So a cervical thoracic correction was probably the better answer, rather than trying to think about an intracervical correction. And he had primary soft tissue envelope, so we were able to do this without plastics involvement. So he had a C7T1 Simmons. And I instrument him at that point from 3 to T4. I probably nowadays would go a little bit longer. We can talk about pros and cons around fixation, but he had multiple really good points of fixation, proximal and distal. And you can see that really large osteoclasis gap in the front. I wish I had recorded his, because this was one of the loudest ones. I still remember it, whatever it is, 8 to 9 years later, how loud that crack was when we corrected him. Kept him in a collar for about 3 months post-op, and around that 3-month mark, took him out of his collar, and this is what he looks like. And I'd argue, we got his chin brow angle really nicely aligned, right restored back to a horizontal gaze. His thoracic spine looks, unchanged, looks about the same. Coronally, we've got him in a nice position as well. So really, like, very, very pleased with the outcomes, with the results. And in this case, things went really well. He did have a little bit of transient C8 weakness. So he had a little bit of numbness and weakness in his hand that had gone away by that 3-month mark, but really did quite well. He also, grew hair and started smiling more. So other factors that maybe don't get measured in an NDI or an ODI. So what are the limitations though, right? It's not a perfect technique. It's opening wedge. So you're limited in bone contact, really, like the amount of bony connection between the proximal and distal components after the osteotomy could be pretty limited. So you're really relying on construct stability. Luckily for most of these patients, bone quality is good or can be made better, but you are somewhat limited there. You do have this uncontrolled anterior release. I mean, yes, we control it. We hold the head, and I'll show some pictures about how we do these things now, but that maneuver is a bit uncontrolled, and there have been some case reports and many surgeons have talked about neurological injury during that maneuver, where the spine proximally and distally becomes disconnected and can shear or pivot in any direction. And then this concerns around loss of fixation and correction. So a while back, people started talking about maybe applying the idea of pedicle circumflexion osteotomies, PSO maneuvers, instead of the lumbar spine, but maybe applying them to the upper thoracic spine near the cervical thoracic junction. Closing wedge osteotomy, you get a lot more bone contact, should be a lot more stable, should be quite powerful correction. And the idea here would be, again, to take an osteotomy posteriorly and to get correction by using either a pre-bent rod or bending it to the rod, or correcting it and then placing the appropriate rod. But correction in that maneuver of a closing wedge as opposed to an opening wedge anteriorly. So this is another patient of mine who was a 44-year-old gentleman that had a history of ankylosing spondylitis, had really severe back pain, and also had lots of complaints around cervical deformity. But when we assessed him, if you look at his thoracolumbar spine, if you just look at his TL spine, he's got a really flat lumbar spine. He's got a really kyphotic thoracic spine, hyperkyphotic upper thoracic spine. So this is a situation where you've got a fixed deformity. And yeah, you may have a global cervical deformity, but this gentleman also has a pretty substantial thoracolumbar deformity. So this is a patient who first had a thoracolumbar correction, right? Had a mid-lumbar osteotomy. Again, nowadays, maybe we'd go even lower, but at that point, we did a mid-lumbar osteotomy with really, really good global correction. We get his C7 plumb line to be substantially better than where he started, but he's still not happy about his cervical alignment. He still complains that he can't look ahead, and he's not happy with it. When we measured him, his chin brow angle was down to about 15 degrees. It wasn't too bad, and I think I spent quite a bit of time trying to talk him out of it to really try to figure out if we were going to help him, but he really wasn't happy with it, persisted, and so I ultimately made the decision to proceed. These are some intraoperative images on how the technique is done now, at least for me. This is what they may look like prone on the table, right after once we've got them positioned, and positioning is a big chunk of the battle oftentimes in these individuals, especially with more severe kyphosis. And as we think about how do we assess them, there's lots of different ways to look at alignment in the OR. Back in the day when they were seated, we would sort of look and see is their gaze moving ahead, but even then they're seated, they're not standing. And now here we've moved to more prone positions. So what I've started doing over time is trying to make a bit of a correction in my mind about how I view these patients when they're laying prone. If I think about the table as representing a vertical, right? They're laying on the table, and we think about the table as a vertical. We try to get the Mayfield in line with their field of gaze. So the gaze is the orange line, the blue line is the vertical, and the angle that's subtended then should represent a gaze angle, right? The opposite of the chin brow angle. To change that perspective, let's turn it 90 degrees counterclockwise. So now imagine this person wasn't intubated on the table, but they were standing, right? And now we've got the vertical, we've got a line in line with their gaze, which is perpendicular to their chin brow. And now we've got an idea about what their gaze angle looks like, right? Which is, again, a bit of a corollary to the chin brow angle. So we measure it. What I do now in the OR is I measure it in the office. I measure it when they're on the table. And I take this picture just like this in the operating room. and I keep it on my phone and I keep it available throughout the case so I can compare. We go through the corrective maneuver, and then we do an intraoperative assessment of the patient to see what their alignment looks like under the drapes as best as we can. And then before they leave the table, before we take them off the table, we take another post-op picture to get some eyes on where are they at now. So this is that patient, that same patient after his PSO and after correction. And again, I'm going to turn that image to the right, 90 degrees. So this is our pre-op, and this is our post-op. And I hope I'm being clear on how I'm using this because I've developed this just over years. But the idea is trying to use the Mayfield and then the Jackson table as analogs for gaze and for vertical access. And that's how at least I try to look at them in the OR. I'm curious, Wellington and Sri, what you guys have seen, or anybody else on the call. And this is what he looked like afterwards. We got a lot of posterior correction, some degree of anterior closing wedge correction, and a much better, chin brow angle for him. This is his standing film on the left before and his standing film on the right after all has been said and done. And so if we think about his global alignment and then focally at his cervical alignment, a much better endpoint than where he started. There are some complications with these procedures. Same thing again, C8 or T1 root symptoms can be quite common. Dysphagia, I didn't mention that earlier, but dysphagia from a cervical correction, that can be a real big problem. We've seen that. I think as you get them into a new alignment and as you do that, you may stretch their esophagus a little bit. You may change the parameters in which they've been swallowing for a long time, and that can create some short-term dysphagia problems. These patients, I prepare them all for the possibility of tube feeding or peg feeding post-operatively, because sometimes the dysphagia can be quite severe. Cord injury, another risk. The risk of a loss of correction or failure of fixation, especially in neuromuscular patients. And then as we do these corrections, the old seated techniques, there are a few case reports of air embolism. I'm not quite sure if I understand completely the mechanism, but it's certainly a thing that's out there that as you do these corrections, you somehow can create an air embolism. But I don't really understand the mechanism of that discretely. So the last case I want to share, I show, like everyone when they give these talks, we always show like good cases, right? We always show like our victories and our successes, and I'm gonna show you one of my failures here, just to demonstrate how much we're all still learning. So this is a patient I had seen when I first got to Northwestern. 83-year-old gentleman. He was a retired ophthalmologist. He had a prior thoracolumbar fusion. He had a prior extension of his fusion up to his cervical spine. Unfortunately, had a lot of continued pain. So the decision by another surgeon was made to remove his implants. And then over the preceding 4 to 5 years, he gradually, progressively went into further and further kyphus, right? So at one point he was fused, implants were removed, and we see that deformity just progressed over time. Not quite sure why one screw was left behind. I don't have an answer for that, but it was there. This is his upright film on the left. This is a bolstered image on the right, supine bolstered image. And I'd argue, unfortunately, there's not very much movement there at all. There's very, very little movement. So suggesting, again, a relatively fixed deformity. This is MRI scan, again, showing that cervical thoracic kyphotic angulation here, as well as then a tight canal up top. And so we took him for revision. I did a T1 PSO. In his case, I did take him up to the occiput, given the severity of his deformity and the fixed nature of it. Also, I just wasn't sure how much correction I was going to get, and I wanted to lock him into position. And we got him corrected. I mean, if you look at his Cobb angle across the area of the apex of the deformity, it's better. We got his chin brow angle better, and he was able to eat again and drink again, which he wasn't able to do for quite a while before. But he had a lot of pain, and he just continued with really terrible neck pain. And while that could just be the nature of the problem, the nature of a multiply revised spine, I also do really wonder if I just undercorrected him pretty dramatically here. And I think 8-9 years later in my practice, I probably would be a lot more aggressive about correction. I probably would think about a lower level of correction. So maybe not T1, but maybe even getting into that upper thoracic spine, and maybe even doing a couple level osteotomy to really force the issue of correction. Again, in hopes that that would have improved his neck pain. So let me conclude, and then we can talk a little bit about what everyone else is thinking. So cervical deformity, again, uncommon, but I think you'll understand that it has a high impact on patients. We don't understand the why and the who of deformity very well yet in the cervical spine. And so those are some really good unanswered questions. There are those key determinants of treatment. Remember, fixed versus flexible deformities, local versus global deformities. And then thinking about this as a cervical only versus a cervical thoracic lumbar deformity, key concepts there. And then with correction, remember, it's risk and reward assessment constantly. Remember, you need, strong rigid fixation. You need really safe technique. And as we mentioned, there's a ton of work that goes into the perioperative management of these patients that you need to make sure we have really good eyes on if we want to take care of them safely. So I'm going to stop there. I'd love to have folks go off mute and ask questions or challenge things I said or take the discussion a little further.
Hey, Al, great talk on such a complex subject. I can't help but still think about your comment on how rheumatology associations may be advising against these kinds of surgeries for AS patients. And so it got me to thinking, for that 44-year-old case that you saw, and so maybe, if we're not doing, maybe as a surgery population, maybe we're being aggressive. Let's just assume that for a sec. And let's say we should only be doing these surgeries for people who have dysphagia or, can't lift up, have really severe, chin brown angles that they looking at their feet all the time. Let's just assume that for a sec. If you see a 44-year-old who has a fused spine and has AS and has already kyphosis, do we know the natural history of what the rest of his life will be? Meaning that will his deformity progress? If it does, what is the mechanism? Because he's essentially fused. And do we know what do you tell him? Do you say that, yeah, eventually you will get dysphagia and it's better perhaps to treat it earlier, rather than later when you're 83 years old?
I think you're bringing up awesome questions, like really, really important questions. And obviously, by me saying that, I don't know the answer to those things. I don't think anybody does. What's interesting about ankylosing spondylitis, and when you talk to rheumatologists about this as well, to them, it's a bit of a head scratcher. So it's a ankylosing or stiffening condition, right?
Yeah.
So once a deformity is created, it really shouldn't progress and change, right? It shouldn't work. Right. But yet we know it does. Like we see these folks, not everybody, we don't know all the predictors for deformity progression, but we certainly see folks who gradually go into kyphus with a condition like AS. So there's been some theories, you're probably aware of them, right? That talk about like microfractures, or there are microfractures in the bone, and the bone gradually remodels into kyphus. Is it a little bit of that shift of the weight-bearing axis of the cervical or cervical thoracic spine that gradually deforms the bone? This concepts around like plastic deformation of bone over time, or maybe viscoelastic kind of creep almost in the bones. I don't think we really know. So to your question about, can we predict somebody with mild disease progressing to more severe disease? I don't think we can. So in general, somebody with relatively mild deformity, I'm going to just watch, you know what I mean? And I'm going to wait for it to become a problem because these are big surgeries. And I think while there is a logic to saying tackle it when it's relatively easy to take care of, right? A 15-degree curve is much easier to take care of than a 30 or 40-degree curve. I also don't know that universally all those patients are going to need something. And so if they're doing pretty well symptomatically, I would just soon watch them. But what do you think? What do you do in your practice?
I'm definitely telling these folks that typically they don't progress. I mean, you're right, we do see them progress, but I feel like when I've seen them, the ones that I've seen progress, I see at the end. I don't typically see, at the beginning, follow them and then they progress over time. Like when I follow them, I feel like they just stay the same.
Yeah.
And then so it makes me think maybe I think they progress because I'm only seeing them, at their end stage, and maybe they were like that the whole time, or what have you. But
it might be it's certainly a bit of selection bias, right? Like we'll only see the people who progress, because if they're not progressing and they're doing well, they may never even come across our paths. What I don't know
Right.
also is, what's the impact of some of the biologic therapeutics, does that prevent progression of disease? Does it prevent
Right.
progression of deformity? Like in the RA population, certainly I think we've got pretty good evidence and anecdotal evidence that says, or anecdotal information, we're not seeing the bad cervical deformities that we used to see, right?
Right.
But AS, I don't know. I don't know if the general feeling I've gotten looking at the rheumatology literature is that any therapeutic intervention for AS is going to try to stop progression, not necessarily reverse it.
Right.
But I'm not sure. But most of those clinical studies have been geared at symptoms of pain, right? Not so much radiographic progression.
Yeah, and I wonder in my mind if let's say we were able to define the age at which somebody fuses when they have AS, when they have bridging syndesmophytes throughout their canal. If you bridge earlier rather than later, are you more likely to progress? So, like, I'm just kind of thinking out loud. I really don't know the answer to that question,
Yeah.
and that could affect whether or not we advise somebody to have earlier surgery, or maybe that's a reason to.
Oh, it absolutely could. Right. And you can probably argue both sides of it. So in the end, the answer is we don't know. And I think what you and I probably both do and what many surgeons will do is say, okay, well, I'm not sure. So I'm going to just keep an eye on it. I'm going to maybe have them check in periodically. I've got a couple of AS patients that I see, now probably once every couple of years. Mostly, honestly, to keep an eye on them, but also out of my own curiosity to see what we can learn.
Right.
Yeah.
Yeah. Great talk.
Thanks. Yeah, no, it's a lot to unpackage, and I definitely simplified a lot of the concepts, and I definitely, diluted some of them. So I'm happy to offline or now go on in more detail on many of them. I don't want you guys to worry as residents that somehow you need to see this all when you're in training. You're probably not going to, right? Because these cases come on maybe once or a couple times a year where we see somebody with a substantial cervical deformity. But if you understand the principles of it, you'll be able to manage the patients pretty effectively. Sri, are you on the line?
Yeah, I was just gonna say sorry, I came in late. We're just finishing up in the OR, so I just caught the tail end of the talk, and it just the part where I came in was when I saw that guy, the patient, upright, and I was really surprised to see that. I thought people didn't. What was that earlier in your career, like in Utah, or?
That was really early in my career. That was actually in Philly. That was actually when I was a fellow.
Really?
As soon I did that, I did a couple of cases, 3 or 4 cases seated, and then I never wanted to. And I did one prone, and I said I'm never going back to seated ever again because it's such an ordeal to get them set up and lined up, correctly.
Right, certainly. And then I would think like anesthesia doesn't really like upright position for this kind of major surgery with blood loss and everything.
Yeah, I think they have concerns over it, but honestly, they don't like prone either. These are just tough. These are challenging patients, right? They're big corrections, they're big blood loss, they're tough airways. So, the positioning, I don't think is their main concern. It's just in some respects, sometimes, prone cases, some of these folks with really terrible deformities, positioning them prone on a Jackson's tough. You're sort of like deep in the well of the Jackson table. And so, there are some neat ideas on how to work that, on how to use the Jackson in the setting of kyphosis to still make it work. But positioning is so hard on these cases.
Right. And so I think I missed, a couple things when kind of assessing these patients. So I missed the first part of your talk. But so if you have patients with exaggerated, cervical or like high thoracic kyphosis, but normal, C2, C7 lordosis, normal cervical SVA, your go-to would be, a thoracic osteotomy, right? Like a T2 or
I think
T3.
Increasingly, I'm thinking more and more, you got to go to where the deformity is, even if that's a lot harder, right? I think back in the day, we used to just stick to our cervical restorations, right? A cervical restoration of alignment, or maybe a 6-7 osteotomy, or a C7 or a T1 PSO, that kind of thing. But again, just from patients, like I shared one case where I think I got a really bad undercorrection. I think in those circumstances, I'm now learning to just go more towards the apex of deformity, and just to be a lot more aggressive with the degree of correction I'm going to get. I think it can be done safely. I think it does add time to the case, and it certainly takes a little bit more effort, obviously on our end. But I think in the end, I end up being happier the more, if I'm going in to fix them, their angular malalignment, I think I'm becoming more and more fixed on the idea of getting it right in the OR.
Yeah, makes sense. Makes sense.
You do have to worry about overcorrection. I've never had it happen, but in theory, if you overcorrect them, I guess with overcorrection, I'm more worried about occipital cervical cases where they might be, fused and fixed to the occiput. So you do have to think about overcorrection. You don't want them looking up, right? Because then they can't see the ground. They're in that permanent tourist mode where they're just looking up all the time. People don't like that, but if you leave the occiput alone and folks who have motion there, I think you have a lot of freedom because they can accommodate really quickly.
Gotcha.
Yeah. The only thing I would say as you think about these cases is that every time I do one, I learn something new in terms of either technique or honestly in terms of outcomes and complications. I think every patient teaches me something new. You name it and it might show up afterwards. So just don't be surprised in these settings. All right, I think we'll probably wrap up unless there's other questions. I'm sorry, I don't know what our next topic is going to be. I've been a little bit off.
I think it's me with instrumentation techniques, if I remember right.
I think you're on the 29th, right?
Yeah, February.
Oh, February. Got it. Okay. So yeah, so we'll make sure we get emails sent out. Sorry, I didn't know that off the top of my head, but we'll get emails sent out as well. Do me a favor if you guys don't mind. I'm just noticing, unlike last spring, we have a lot fewer people logging in. And I don't know if that's just because we've all gone back to life and there's more things to do than when we were all stuck at home. But if there's ways we need to communicate this better, let me know. I'd like to make sure we're getting this to all of our residents as well as then to the neurosurgery residents at the very least.
Yeah, sounds good. I'll ask around, see if.
Yeah, just get some feedback, and for all the residents on, let me know. If the emails aren't enough, we can come up with some better ways to make sure we get reminders out to everyone. Otherwise, I think the discussion's great. So thanks again for tuning in.
Thanks, Dr. Patel.
All right, guys.
Thank you.
It's funny because he saw me and Mo just walking